everyone. Let's start challenging case presentation 3. First,
Nice to meet you. So my name is Dr. Siddharth from India.
Dr. Richardson Olia, please.
Hello, good afternoon. I am Richard Sonby Lurilia from Manila Doctors Hospital, Philippines. So today I'm going to present a case of a complex and high-risk coronary intervention with left main bifurcation stenting. I have nothing to disclose for this particular case. So for our case, we have a 64-year-old male who came in with a chief complaint of dyspnea. He is known hypertensive and diabetic and on optical medical management. He had a history of 20-pack years smoking history and occasional alcoholic beverage drinker. History started about 1 year prior to the consult. Patient had progressive exertional dyspnea accompanied by chest discomfort and easy fatigability. Consult was done and 2D echocardiogram showed with an ejection fraction of 22% with global hypokinesia. 12-lead ECG showed a sinus rhythm with a non-specific ST wave changes. There were no viability studies done for this patient. He had a normal kidney function with a creatinine of 1.1 mg per deciliter with an eGFR of 75. Patient then was advised for coronary angiogram, and upon finding of the result, patient was then advised for coronary artery bypass graft revascularization, but patient refused. So this is the coronary angiogram done for our patient. This is still pictures, images, which showed severe three vessel coronary artery disease with left main involvement and a right dominant circulation. This is the LAO caudal view showing a left main coronary artery with 70% distal segment stenosis, bifurcating into a left anterior descending artery with an 80% ostial segment stenosis and a left circumflex artery with a 70% osteoproximal segment stenosis. Another view is an AP caudal view showing the left circumflex artery, which is a large size vessel with a 70% tubular stenosis at its mid-segment. Another view is an RIO caudal view showing the left the bifurcation with the previously mentioned stenosis. This is the cranial view showing the left anterior descending artery, which is a large size vessel with about 80 to 90% stenosis at its mid-segment with a hazy linear opacification consistent with a dissection and or calcification. This is the LAO cranial view. And for the right coronary artery, the AP cranial view showing the right coronary artery with luminal irregularities along its course and a large size right posterolateral branch with 70 to 80% focal stenosis at its mid-segment. Another view for the right coronary artery is the LAO view. So what we did, we proceeded with the left main bifurcation stenting. First is the wiring of the LAD with a pre-stent dilatation of its intuition PCI wire, the LCX, deploying of the stent, rewiring the side branch at the LAD, opening of the main vessel struts, and then balloon at the main vessel using the tap technique with the protrusion of about 1 to 2 millimeter, and side branch stent deployment, side branch and multi-vessel, the main vessel alternate balloon inflation, and the final kissing balloon technique. So post-stent dilatation was done for the LCX and the LAD. Post-PCI angiogram showing the left main, LAD. So after we proceeded with the coronary angioplasty of the RCA, deployment of and the post-angiogram of the right posterolateral branch. So we concluded with a successful left main bifurcation stenting using a tap technique. So this is just a still picture of a step-by-step process of a left main bifurcation stenting using a tap technique, the wiring of the side branch and the main vessel branch, and the pre-stent dilatation of the main branch, the main vessel, the left main to the LCX, deployment of the stent, and then rewiring of the side branch at the LAD, and then using a tap technique with a minimal protrusion about 1 to 2 millimeter to the main vessel, and then alternating balloon, inflation, and then the final kissing balloon technique. So just to show you the before and after, this is the pre-stent deployment of the left main coronary artery, deployed here, the left main to the LCX and then to the left anterior descending artery. For the circumflex, this is the post-angiogram, and for the anterior descending artery with the vasospasm after the stent deployment at the mid-segment. For the right coronary artery, this is the pre and post with the focal stenosis at the right posterolateral branch and then the post-angiogram of the right coronary artery. So the final angiogram result showed a TME3 flow with no dissection or no loss of branches with a good flow. So the patient tolerated the procedure with no hemodynamic instability. Patient was discharged improved and stable on a day 3 of hospitalization. Patient was maintained on dual antiplatelet therapy, the aspirin and ticagrelor. And on follow-up after 6 months, the 2D echocardiogram showed a marked improvement of the LV function from an EF of 22% to 45%. So for the discussion points, high-risk patient presenting with increasing ischemic symptoms such as angina, refractory to medical treatment or heart failure are thought to be appropriate candidates for coronary revascularization. Benefit of achieving more complete revascularization in high-risk PCI patients presenting with multi-vessel coronary artery disease and low LV ejection fraction showed a marked improvement after revascularization. So another discussion point is a one stent versus a two stent strategy. So most of the are advocating a provisional stenting strategy is recommended for the majority of coronary bifurcation lesions. A two stents technique targeting the main vessel and the side branch is sometimes required when a large side branch is in jeopardy, just like in our patient. This technique is associated with a reasonable clinical outcomes. It provides a full side branch ostial coverage while avoiding the deployment of excessive hardware. The end result is achieved by creating a neocarina composed of a layer of one single stent strand due to the intentional minimal protrusion on the side branch stent within the main vessel stent. So for our case, we use a tap stenting, a T, and a small protrusion technique, which is relatively simple as it follows full coverage of bifurcation lesion and facilitates the final kissing balloon. So to conclude, we have a 64-year-old male, known hypertensive and diabetic, presented with heart failure symptoms with a severely reduced ejection fraction of 92%. Coronary angiogram showed a severe 3 vessel with a left main involvement of Medina classification of 111. Patient offered for bypass but opted and refused and opted for a multi-vessel PCI with left main bifurcation stenting using a TAP technique. TAP technique was used for the following reasons: for the bifurcation angle of more than 70 degrees and a long side branch lesion. Successful complete revascularization of a high complex risk bifurcation lesion using a two-stent TAP technique. So, thank you and mabuhay.
Thank you for presentation. Any questions or comments from the floor or panel?
Yeah, actually, the steps you have enumerated very in a detailed manner. Have you described about the pot when you do tap technique? Do you use pot and how many pots? I don't think so. You have shown pot in your steps.
Actually, for this case, we were not able anymore to do a pot. We just ended the procedure with a final kissing balloon, but advisably,
Even when you tap, before putting a second stent, it is recommended to do a first pot.
Yes.
Before, because that creates a better space to rewire your this thing, and secondly, your stent gets apposed proximally properly. So that is a very important step which one should do, not miss. First part should be done, and the second part in TAP technique can be done slightly cautiously, putting your pot balloon just before Carina. So these two parts I think are important in this case.
Yes, noted, sir.
First of all, I'd like to congratulate you, doctor. So I wonder, I mean, this case is definitely is a cheap case, it's a cheap PCI. So I think the important discussion point whether it's a use of MCS in this case because of EF is very low.
Yes, yes.
Secondly, is intravascular imaging.
Yeah.
It was well aware by ESC guideline that use of intravascular imaging, especially in left main bifurcation, have the benefit. And then last is the DAPT duration. You plan for this case?
For at least a year or 12 months.
All right. So I presume there's no intravascular imaging?
Yes, the IVUS was initially, but however, initially contemplated, however, during the procedure time, the angiogram and the PCI was done on the same day, on the same setting, but the IVUS at the time at our institution was not available.
Sure. Dr. Richardson, in your center, how do you decide which patient need MCS for when they're going for PCI?
Yeah, for our institution, we don't have any available, but we have support like IABP. But luckily for this patient, the patient initially was admitted stable, but with heart failure symptoms. However, the vital signs were stable, and all throughout, we just got lucky that the patient remained stable and able to endure the procedure without any arrhythmia, any hemodynamic instability. But initially, we planned to put IABP, but the issue at this time was the costing, so we were not able to do so.
Thank you very much. Congratulations.
Thank you.
As you said, there were symptoms of dyspnea. Just a quick question. As you said, there was
sorry, I'm very sorry, but time is shortening. So let's go to the next speaker.
Thank
you very much. Next presenter, Dr. Imad Shivan, please.
I am Imad Shiban, Director of Interventional Cardiology at Pedersoli Hospital in Pescara, Verona. I'd like to thank you for giving me the opportunity to discuss with you this challenging case of complex multi-bifurcation procedure. I have nothing to disclose. We know that coronary bifurcation lesion intervention is challenging and complex, particularly when consecutive multiple bifurcation lesions have to be treated at the same site. And intervention on bifurcations have greatly evolved in the last 10 years, refining both simple and complex strategies. And that's because of different platforms at the present time, improvement of basic strategies based on more detailed data coming from bench testing and clinical practice, more use of intravascular guidance, more use of effective devices for calcified lesion preparation, and more clinical data coming from improved clinical outcome. The key issues is like in any complex PCI, that means plan the strategy and follow the fundamental steps to obtain an optimal result. Inspection, lesion preparation, stenting, and final optimization. Now, let's go to our case. This is 78 years male with conventional coronary risk factors, hyperlipidemia, hypertension, familiarity, and peripheral artery disease. On 22 July this year, he has a first episode of chest pain on exertion lasting for 3 minutes. And the day after, he had prolonged chest pain on rest, and he was admitted to our hospital for non-ST elevation myocardial infarction. On arrival, he had persisting chest pain, normal blood pressure, normal pulse, normal oxygen saturation, normal creatinine, but T-troponin was already raised to 357. On ACG, ST depression in inferolateral wall was present, and on echo, left ventricular normal volume with moderate inferior and apical hypokinesia. Ejection fraction was 0.52. This is the coronary artery, right coronary artery, which was totally occluded at mid-segment, and this was considered the culprit lesion for acute coronary syndrome. On left side, you can see that there are complex bifurcation lesions, multiple bifurcation lesions, starting from distal left main, the proximal circ with acute marginal, and the proximal LAD with diagonal, and another bifurcation also on diagonal itself. So we had 4 bifurcation lesions: distal left main, LAD first diagonal, diagonal bifurcation, and left circumflex with obtuse marginal. Of course, we started with the culprit lesion treatment. RCA was recanalized and stented with good final result, and we plan to complete revascularization before discharge after heart team discussion and patient consent. Discussion was made accordingly to syntax score 1 and 2. Syntax 1 was 30, so intermediate lesion, intermediate patient with no difference, significant difference in the outcome at 5 years in between the surgery and angioplasty. If you look on syntax score 2, then PCI had less mortality at 4 years as compared to angioplasty. So patient preference was to PCI. We started with inspection, that means intravascular OCT, run from LAD to left main, showing that there is osteoproximal lesion with area of LAD of reduced, as well as POC area reduced, as well as distal left main area reduced, with a lesion length of 21 millimeter. No severe calcification, that means no need for debulking devices to prepare the lesion. And the other run is baseline run from obtuse margin to left main, again showing the reduced area on proximal osteoproximal circumflex, POC area, and distal left main area, as well as lesion length here again is 70 millimeter. And again, no severe calcification, that means no need for the debulking devices for lesion preparation also at this site. So we planned our procedure accordingly. 7 French guiding catheter, intravascular guidance to continue with OCT for procedure guidance and optimization. Then treatment on the 4 bifurcations, that mean distal left main with DK crash, LAD diagonal with DK mini culotte, and both the other bifurcation with provisional stenting. We started as first step from LAD diagonal bifurcation with lesion preparation, stent deployment in diagonal, preparing for culotte stenting, optimizing stent expansion of the position on diagonal, as you can see here schematically. This stent was realizing provisional stenting at the diagonal bifurcation, and the protruding part here in LAD was prepared to receive appropriately to anatomy and to receive the second stent to complete the culotte stenting. So step by step, pre-dilatation, stenting diagonal, then stent fenestration to the distal LAD, first kissing balloon inflation, pot in LAD, and what we have schematically shown here is good apposition, good conformation of the stent to the anatomy and to the anatomy of bifurcation, and ready to receive, to be completely culotte with a main vessel stenting. Then we moved to distal left main treatment, distal left main for DK mini crash, and with provisional stenting to L circumflex obtuse marginal. Again, lesion preparation, stent deployment in marginal protruding bit in left main, and this stent was realizing the provisional stenting between the circumflex, proximal circumflex bifurcation, that means circumflex obtuse marginal. Then with stenting, the stent was crushed with a balloon already present in lift main to LAD, which was 3.5 or 15 NC balloon. The stent was crushed, then recrossed proximally with a wire, and then first kissing balloon inflation was done, and this was completed like you can see in this schematic representation. That means preparing the stent to be completed as with DK crush and distal lift main. Now, last step was stenting stenting the main vessel. That means from lift main to LAD, completing the DK mini culotte on LAD and first diagonal, and DK mini crush and distal lift main. Again, schematically, you can see what we have left here. The stent ready to be completed, stent on diagonal ready, the protruding in LAD, ready to be completed for culotte stenting. The stent here in obtuse marginal to proximal circumflex crushed in distal lift main to be completed with DK crush, and the stent, single stent completing both strategies. That means the DK mini culotte and with the first diagonal, LAD first diagonal, and DK mini crush at distal lift main. The stenting was completed, optimized by recrossing again the stent to diagonal, doing a second kissing balloon inflation and pot in proximal LAD, recrossing the stent to obtuse marginal and doing second kissing balloon to complete DK crush here, and the pot in distal in lift main was done. Final pot was done with 4.5 balloon per 12 millimeter inflated at 18 atmosphere, and these are the steps you can see. And this is the stent push showing what we have obtained finally with all these steps. And the procedure was completed with the final OCT run from LAD to lift main. And you can see the both ostium are free from any bulky apposition of metal. Around good expansion of the stent, good final areas obtained as in at mid LAD segment, proximal LAD, at distal lift main, proximal lift main with good apposition, good expansion of the stent, and the final run also from circumflex to lift main. You can see again the same, that good apposition, good areas obtained at distal margin, obtuse marginal, proximal circ, distal lift main, and proximal lift main with good stent expansion and good apposition. So everything in place and optimized. This was a final angio, confirming what we have obtained from what we have seen in on intravascular imaging. So in conclusion, multi-bifurcation angioplasty is a complex procedure and need to be planned appropriately. Intravascular imaging is crucial not only to evaluate the severity of disease, but also to define the plaque characteristics, disease extension, and bifurcation complexity, and to select accordingly the appropriate lesion preparation approach and the appropriate strategy for bifurcation lesion treatment. Whatever the selected strategy, stepwise approach, and intravascular guidance can be can make the procedure more easy and safe for the patient. And final optimization with complex strategies is mandatory to be guided by intravascular imaging, which impact favorably the long-term clinical outcome. Thank you very much for your attention.
Thank you very much, Doctor. Because time is shortening, this case is a good strategy and good procedure and good result. Let's move to the next speaker. No. So because the next speaker is not here yet, but so the time we have time. So any comments from the floor or
I had a question, sorry, for Dr. Shiban.
Please.
Is he offline or is he still there?
It's recorded.
I think he's offline. I had this thing about these kind of bifurcation lesions when we are talking. There's a lot of new data that is coming, especially from the EBC, where we are seeing that drug-coated balloons can often get you out of that situation where you're doing a provisional, and they do a report, in fact, with that same drug-coated balloon. So I wanted to know any experience here, particularly with the forum or anybody else, how to decide where you would go with a drug-coated balloon and where would you actually think of a two-stent strategy in a provisional, this thing, of course.
Thank you. Any
In
comment?
fact, that's actually a question that I like to pose as well. Because I don't personally with this Imaxiban, but too many metals into the diagonals, I don't really prefer it. So
Exactly.
I think we are in Malaysia, we really like the DEB and just the diagonal. But again, the decay crush in the left main is absolutely fantastic.
Exactly, but that's what I felt the
so
same
at least
thing.
less metal.
Less metal, and
yeah.
if it's left main, yes, I do understand, but when you have diagonals like these, I would not really worry too much about them. Maybe just a DEB there would do it.
But it depends on whether you are
Yes, of
DEB believer or not.
And just to add to what you mentioned earlier, yes, I do agree with provisional stenting. Actually, he put a lot of metals, and I don't know how long the procedure does it take. I think it takes so a long time. He using OCT and putting all these stents. But looking at the angiogram, actually the flow in diagonal branch is symmetry flow. So maybe, yes, we go for a provisional stent, LED left main, or a decay crush for LED left main circumflex rather than decay crush in diagonal LED and others. All right.
Maybe I also make some comments, short comment. First comment is that in our practice, we found that DEB work, but in study, there's no good evidence, no good randomized trial to have a positive result so far. And the second consideration for us in our practice is the money, because DEB is more expensive than conventional balloon. So nowadays, if the patient can afford, we may consider DEB, but have to inform the patient. We don't have enough evidence, but experience-wise, it's okay. That is our sharing.
I'm Malaysian. I'm currently attached in Japan. So suggest my center is doing some, and some Japanese cardiologists is doing some DCA, DCB strategy, directional coronary arterectomy for plaque reduction, then subsequently apply a DCB. So this, some of the small studies that show that the result was promising. The use of them are actually complementary to each other because DCB work by you need the contact of the drugs towards the coronary vessels, and if you use a directional coronary arterectomy where you reduce the plaque burden, thus when you use a DCB, the accurate result is actually quite okay. And they have some small studies from our Japanese colleagues published. The 12 months outcome actually are quite reasonable.
Yeah. In that case, I think DCA is a very good choice. I like DCA, and I sometimes treated DCA with bifurcation. In that case, DCA plus DCB is very good strategy. But diagonal and OM is only branch, yes. So it is. I don't have to treat the two-stent strategy. If I use the stent, I treat the single stent and the cavity. And maybe my strategy, just 30 minutes. Yeah, make it simple is best, I think.
Yes, I agree with the comment. And then another option is the simple strategy like stenting LED only and check the ischemia by RI, or then you consider the add the next PCI or the medication.
Sir, basically the strategy for any PCI should be to keep it short and keep it simple, right? So
Yes.
yeah. So in this case, see, a thinner branch, a diffuse lesion, a drug coating balloon would actually be the right way to go, because when you're putting a stent in any branch, obviously there is a chance of restenosis, definitely. Now, when using a drug-coated balloon, there have been instances where inflating the balloon itself can sometimes cause minor dissections there. But I don't think that's a very big worry. So a drug-coating balloon would actually be good here. Thank you.
Okay.
If we, because the last speaker did not show, do we still have some time for discussion? So I agree that DEB is a good choice, but actually there are many bans on DEB. I think the excipient of each type of DEB are different. What do you think about which type of excipient on the DEB is most effective so that you can apply the drug to the diagonal? Because sometimes you need to pass lots of resistance before you can deliver the DEB to there. Sometimes the drug will disappear during the delivery. Do you have any tips and tricks to settle this issue?
Sorry, anybody? So what we normally do out there is we take it first an NC balloon, open it, and of course, if it's an osteal lesion, a cutting balloon has to be delivered so that that kind of makes it that the recoil is not much there, and then maybe deliver a drug-coated balloon there. Data, of course, is very sparse. I agree with you that it's not something that everybody does it across. But when you're looking at these kind of lesions where there are multiple bifurcations, you want to make it simple, and you have a OCT to answer Dr. Bajaj's this thing that, of course, if there is a dissection or so, you can always leave it with the OCT and see if there's any major compromise there or any sort of thing. Of course, the cost dynamics would be different because a stent is cheaper than a DAB, of course.
With regard to your questions, I think with the recent...
The practical problem with using drug coating balloon is that many of the times when we balloon or as you said, use cutting balloon and these, we get dissections. In that case, we have to bail out. You cannot keep dissections like that. That is a problem. That is a problem with you practically using drug coating balloons. That problem always creeps in. That's why it's not becoming so popular also. This technology is now, I think, 6, 7, maybe 10, 15 years now down the line. Still, it's not popular. It is because the basic mechanism of stent of protection that is devoid of that is the main problem. Because if we want to go dedicated for drug-coated balloon on a day when you get a dissection, you have to change your strategy.
For the drug-coated balloon, I don't think any dissection with the good flow is still problematic to us because when we repeat the diagnostic angio back to relook back the effect of the EB, then there's actually lumen gain and the dissection went away. So I'm not worried with the TIMI.
Practically, how many dissections do you leave on table? Practically,
maybe 50%.
You talk practice.
Yeah,
you talk
50%.
practice. How many? If you see a dissection, a interventionist sees a dissection on table, how many us will leave it?
Sometimes I just want the dissection because
maybe even if we are using imaging, still.
But I think it still depends on what type of dissection. So you can leave or you can stand.
Do with the imaging whether it is meeting the criteria for stenting or not, whether it is like they call extending up to media or 300 microns. So these imaging criteria are there, of course.
Yes. One option is you can watch some time and check the flow and decide standing or not to stand.
I think in our Asia Pacific guideline has been clearly mentioned that they sit down and agree that for use of DCB, so anything there's no flow limiting by dissection, I think it's acceptable. And then another criteria is FFR post POBA. then you can decide to use a DCB. So mechanism of a DCB is by drug diffusion. So for us, that's why in the guideline recommend you to use a cutting balloon or scoring balloon to create this control dissection so that the drugs are able to diffuse into the vessels as much as possible. And then I agree with a chairperson, time is the most important thing. I think DCB, the problem is you need a lot of time, you need to balloon and balloon and balloon again, preparation of a lesion. I mean, some interventionalists just stand, okay, finish, that's it. So, but DCB, you need a lot of preparation, and then you need a lot of time to wait and see. I think but I hope that we have more randomized control trial, but it's very difficult. There's only one paclitaxel drug-coated balloon. We have some randomized control trial, but hopefully all this practice will lead to a better outcome for our patient. Thank you.
In initial days of practice, when we used to use balloons, there was an incidence of 50% failure. That's why the vogue of stent comes and they became popular. We cannot ignore that statistics. When we are using balloon, that statistics will always speak. That's the point of view.
Okay. No next speaker. Yes. Let's close this session. Good discussion. Thank you very much for all.
Although we don't have, we can't see two speakers, but we see many good discussions on this hot topic. So this is still a very meaningful and educational section. Thank you very much for your attention and your time. Thank you very much.